Bonus, it de-ages you 30 years. I'm going to go tomorrow. All right. We talked earlier, I know John did, about the effect of diabetes on your eyes, potentially. Something I think we've heard about before, but what maybe you don't know is that it can also affect your ears and your hearing, and maybe directly or indirectly, right? There's a connection. So we're going to be talking about that, what that can happen there. Regina Presley is here. She is the Senior Cochlear Implant Audiologist at the Presbyterian Board of Governors Cochlear Implant Center of Excellence at GBMC. And Brian Kaplan joins us again, Chairman of the Department of Otolaryngology at GBMC and Director of Presbyterian Board of Governors Cochlear Implant Center of Excellence at GBMC.
Well done.
Thank you. Hope you all heard that. So let's just now, in regards to diabetes and our topic today, where the concern comes for hearing and what there's a potential impact there.
Sure. So I can lead us off.
Okay.
When people think about diabetes, they think about eye care.
Yes,
and retina
absolutely.
disease.
Yeah.
There's very few direct connections when you think about hearing loss. But as you take a step back and think about diabetes is not a disease of blood sugar. It's a disease of small blood vessels. And the damage happens to small blood vessels because your sugars get too elevated. And then it blocks off the blood supply, and then you end up with hyperbaric oxygen that we saw in the therapy and the chronic wound care. And if you take a step back and think of what are the parts of your body that get fed by these really small little blood vessels, you think about the back of the eye, you think about the kidneys, you think about the ends of your fingers and your toes, and you think about the inner ear. Those are really delicate nervous structures, and just small blockages in that blood flow can lead to some long-term detrimental effects. So it's so important to control those sugars early on to maintain those small blood vessels in the blood flow and then prevent those downstream ramifications.
And I would imagine, too, if you're of a certain age and you notice a little bit of hearing loss, you might not even make the connection.
So why are you looking at me like that? So that's true, and I'll let Regina add to this. Hearing loss is incredibly common. Right, so about a third of 65-year-olds, half of 75-year-olds have clinically significant hearing loss at baseline. With diabetes, that number jumps up significantly. Many things factor in for hearing loss. We talked about aging, genetics, noise exposure, but obviously anything that affects blood supply will cause an effect on the hearing. The early signs, people come in and say, well, they're just mumbling. I can hear fine, but nobody enunciates the way they used to. I can promise you nobody's mumbling. They're talking exactly the way they always did. You're just having a little more trouble hearing, and it's usually hearing in background noise situations is the first time that shows up.
Wow. Do you ever get someone talking about hearing loss first before they even realize they may have diabetes? Is that sometimes the trigger? Or
usually it's the diabetes first.
Okay.
Hearing loss tends to be progressive in many, many patients, even just from an aging process, but certainly along with the diabetes. And so people don't necessarily recognize it. I mean, think about the first time you got your first pair of glasses. You probably just thought, I've been doing fine. I don't really need glasses. And then you go to get your eyes checked and they say, oh, you know what? You really could use some glasses for reading, right? Just something very subtle. Same thing as Dr. Kaplan is saying is that when we start missing pieces of information, maybe it's our spouse mumbles or, the grandkids are on the move, those sorts of things, and we don't realize the things that we're missing because they just gradually start to fade away. It's not until the hearing loss gets to be more severe then all of a sudden we're like, I'm really having trouble on the telephone. And then it impacts us greater. So it is a very gradual process that often goes undetected.
Yeah, and in fact, I was surprised at this graphic that we had on the screen. Hearing loss is twice as common in people with diabetes compared to those without. I mean, that's significant.
It's significant, and then you also have to think about hearing loss a little more globally, right? So it's more than just, I'm having trouble understanding on the phone or have to turn the TV volume up a little bit. There's a lot of growing evidence regarding the importance of hearing and healthy aging and the link between them, particularly when it comes to dementia. So dementia is something which nobody really wants to talk about, and everyone's afraid of that downstream.
No, let's talk about it.
But it's something that's out there, and the cost to society is enormous, both in direct and indirect costs.
So can you just delve it a little bit deeper? And there is a diabetes link, but we're kind of going off a little bit on a tangent, but that's okay because I think everyone hears the word dementia and we want to avoid it, right?
The diabetes link is in here too. Right?
Okay.
Your brain is filled with those same small blood vessels we talked about. And then the higher rates of small vessel disease and then long-term dementia all factor in with people with uncontrolled blood sugars.
So in the diabetes world, is it so much the hearing in relationship to dementia, or really that's just the more the blood vessels being affected?
It's probably a little bit of a canary in a coal mine.
Okay.
That it's a sign, same as your vision, that they can pick up on a routine exam in the office and say, there are signs here that your sugars may be out of whack. And if you're getting accelerated hearing loss compared to what we'd see for an age-matched normal, you might say we should do a little more investigating into this. What we've learned now is relates to the dementia and the hearing loss. If we treat the hearing loss, we can slow down and in some cases prevent the onset of dementia. And it's really changed the dynamic of
Can
the
you
conversation.
explain more clearly the connection between hearing loss and dementia?
So as we're talking about hearing loss, when we think about the brain receiving information, if we're not getting adequate input, our cognitive decline starts to occur.
Even if we have the other senses working, even if we can see, if we're getting the visual input and we're getting other inputs, losing that hearing input is affecting how your brain processes?
It does. And I think the thing that we also need to keep in mind is that as hearing loss progresses in terms of its severity, what oftentimes people find that they're isolating themselves. They don't even cognitively or really give thought to, oh, well, I don't do that anymore, and why am I not doing that? Even though it is hearing related, they've stopped enjoying it because they can't be an active participant. And so when that happens, they really start withdrawing, and then they're not being stimulated. In turn, their brain is not being stimulated, and we start to see that decline. So the sooner that a patient can be identified with hearing loss and receive proper management, even sometimes it's just monitoring, those things are very important, because the sooner that we treat them, the better the outcome. And for all of us, and that's why all of these individuals are here today, is because it's really the holistic approach. GBMC is looking at providing service on the continuum of everything that a patient who is experiencing diabetes. We need to be looking at all of these pieces, our nutrition and our ophthalmology and our hearing needs, along with all the medical pieces, other medical pieces as well.
It's an overall quality of life, not just an
Absolutely.
isolated field. So broadly, I have diabetes, even if I don't have diabetes. How often should I be getting my hearing checked? Is it more so if I am diagnosed with diabetes or am pre-diabetic? What is the recommendation?
So this is a little bit of a moving target right now, and we'll probably have a different answer for you in a few years. There's a lot of effort going on right now to start screening adults, probably age 50 and over, with a routine exam. You think you get your eyes checked, you get a colonoscopy, you get a blood sugar, as part of a window into what's happening, whether it's the small vessels or other parts of your body. So by getting at least a baseline level of where are you, it lets us decide how often do we need to see you back. If you came in with completely normal hearing, we'd probably say call us if you need us. If you start to show signs of some mild hearing loss, or if your diabetes is less well controlled, we'd say, you probably come back in a year. We should check that. And then we should start talking about intervention for that hearing loss earlier rather than later, given this component with healthy aging and the link to it.
So at least by 50, you're recommending get your hearing, get some baseline.
Well, and I think the thing that's great now is with technology, even if you go to our website, and I think we have a slide for that, you can go to the website, pull up an app on your phone, and sit in a quiet room with some headphones and do your own hearing screening. It doesn't even require a copay or a doctor's appointment. So we can all be very active in our hearing health. And then if that screening suggests that there needs to be a further exam, that's when you would reach out and have a full exam.
I have lost some hearing in my left ear, high pitch. And you know how someone told me to rub my two fingers together and hold it up next to my ear, and I can hear, you should be able to hear that, but I can't hear it in my left ear. Can you hear that? And that was my first sign that I had some hearing loss.
Come visit.
I know I should. It's been a while since I've been checked again, so I definitely should. So what are the options available for someone who has mild hearing loss, moderate, significant? I'm sure you kind of you denote like where you are on the continuum, right? What then?
So again, that's a continuum. It goes from just early diagnosis and monitoring to then hearing aids can often be used for mild, moderate, and some types of severe hearing loss. When you think about hearing loss, you have to break it up. There's how loud does that beep have to be for me to hear that beep? And then how clearly can I understand speech? And they're very different items that we test for. A hearing aid addresses how loud does that beep have to be. It does not address how clearly can you hear speech. So for most folks in mild to moderate and early severe hearing loss, all they need is amplification. The sound stays nice and clear when they put the hearing aid in. There will be over-the-counter hearing aids coming in about 18 months across the United States.
Wow, what do you think about that?
I think it's great. 80% of the patients today in the United States who should be wearing a hearing aid are not wearing a hearing aid. So the more awareness and education that we can get out nationwide about the importance of testing your hearing and treating your hearing will both help quality of life and cut down on falls and social isolation and depression and potentially dementia, which will be an enormous benefit to society. Once hearing aids don't become enough, once they say, yeah, it's just louder garbled noise, now is when we start talking about cochlear implants, because that actually restores the clarity of the sound, not just the volume of the sound. But that's more for the moderate to severe to profound segment.
John, I want to get to your question before we go off, continue on the conversation.
So this question is, here we go. This question is from Mel. Can an ENT in looking in the ears determine a problem into hearing loss due to diabetes?
Great question. So typically, no. When you think about hearing loss, there's two main categories of hearing loss: conductive hearing loss and sensory neural hearing loss. Conduction means something's just physically blocking the sound from getting in there. That's usually something we can do something about. We can often tell by looking in someone's ear. That's not typically what diabetes causes. Diabetes causes damage to the little nerve endings in the inner ear that can give a normal physical exam, but gets picked up on a hearing test. Diabetics, just a caveat to that, we've all had a swimmer's ear, an ear infection. Little kids get them all the time. In patients with diabetes, particularly poorly controlled diabetes, we started talking about A1Cs in the earlier segment. As your A1Cs start to climb, your body's immune system takes a hit. It cannot fight infections the way it should. It doesn't do wound healing. That's why the hyperbaric oxygen was required that we saw before. So those little ear infections can turn into potentially life-threatening complications.
Wow.
And it's very important. That's why they have you check your toes and check your hands and make sure any wound is healing well. Same goes for any ear infections.
When you start talking about cochlear implants, I would imagine there's some hesitation on the part of, oftentimes, of many of the patients. Do I want to go down that road? What are some of the drawbacks? I mean, how complicated is it? How difficult a procedure is it? And how hard is it to kind of get used to it and live again with it?
So cochlear implant is an outpatient surgery that lasts about 90 minutes. So if you ask Dr. Kaplan, he'll say to you it's a very typical ear surgery. A lot of the patients that we see, although some patients come in saying, you know, I'm not sure about this, and they're anxious just from the surgical standpoint, most of them are to a point where they know that their hearing loss is impacting their quality of life, and they want to make that change. And so they're often the ones spearheading, coming to see us and say, okay, I'm ready to live again. So using the telephone, going to the movies, all of those things. Grandchildren, huge motivator. But there is a period of time for adjustment, but I usually tell patients from the time we turn it on to that 6-month mark, we see a drastic improvement in how people are able to understand speech so much more than they were able to with their hearing aids.
And percentage-wise, I mean, how good does it get? I mean, are they back 50%? Are they back 75%? Does it depend on the patient?
So it very much depends on the patient. There's a lot of work going on right now to be able to give a much better answer, because every patient asks that.
Sure.
Right? All they want to say, how much better am I going to hear? So what we can tell them is, you're going to hear better. There's a lot of factors which factor in to your potential success. How long have you gone without hearing? Have you been wearing hearing aids? What is the other ear doing? How's that status? Are you wearing a hearing aid in that other ear? Age by itself is not all that important for us. Your overall health status. We've done cochlear implants on many patients mid-90s and older. They go home 90 minutes later.
Do you keep the same implant, or do you have to change them out?
Same exact implant, and that's the same implant if you are a 9-month-old baby to a 99-year-old
Are there batteries
individual.
on them?
The battery's on the outside.
So they have to be replaced?
Or recharged. Either one depends what you do. So once you tell folks, hey, we will have you hearing better, there are folks that can hear back close to the normal level. You can't promise that because there's a big variability within that. But you even have you hearing much better. It'll take 90 minutes. It's about a 2-inch incision right behind your ear. All the stitches will dissolve, and you'll be back in the shower washing your hair in 48 hours. That changes the mentality. It gets rid of some of the fear, and now they can spend a little bit more time talking about, okay, well, let's learn more about the process. Probably the single best thing we can do is connect them with previous cochlear implant recipients and let the patients have that discussion. It lends a lot of credibility and does a lot to ease their fears.
Sure, I would imagine so. Question from John? Or from the audience?
Yes. Actually, we have two questions. First question is there intervention for auditory processing?
So auditory processing is a little bit more challenging, and it really depends on.
That's a great question and complicated, I would imagine.
Well, it is, because there's a lot of variability in terms of processing of information. So it's determining where the areas of weakness are and finding strategies that best improve depending on the situation.
And is that when you start talking about a speech and language pathologist coming into the mix?
Sometimes it's speech language therapists, other times it's dedicated therapists who specifically deal with auditory processing delay. Several of the universities around here have programs that we are in coordination with, and we will send the patients around to be able to hit all the different modalities of care.
Because sometimes hearing isn't enough, it's what is happening with that language in your brain.
And
right?
that gets back to the diabetes that we brought up earlier. So with small vessel disease, any kind of cognitive decline or early dementia, if you can't process that information, when you think about what happens when you talk to me, how this is milliseconds by the time it gets processed by my brain so I can respond. I mean, you know how sensitive you are when you're watching TV, and if the sound and the lips don't match exactly, even if they're off by a couple milliseconds, it's a big disconnect. You don't like it. And if that brain slows down even just a little bit, your brain is playing catch up in the conversation and trying to play along and working hard. And that uses a lot of the cognitive load, and it's exhausting. People with hearing loss will tell you they try to go to a party, they go to a work meeting, and they're exhausted at the end of it because their brain is working in a way that we just don't appreciate.
So let me ask you this: for a person with diabetes, and they're losing their hearing, and that's been determined, and they had a hearing aid, maybe they get a cochlear implant, and they're still having difficulty with language, is that telling you possibly that the blood vessels in their brain may also now be affected by the diabetes, and you've got to start working with therapy in a whole different way? Is that fair to say? Have you ever seen that before?
I was going to say, I think that what we need to do is look to see how well the diabetes is being managed. When we look at processing of information, how patients are doing, regardless of diabetes, patients can still struggle. But if you have hearing aids and you're not getting all of the information, it's like looking at half of a puzzle put together, right? And so your brain, you're working double time to fill in the blanks that are being missed. And so people think that they have an auditory processing issue where truly it's that information is not there. So part of it could be in terms of, is it the programming, excuse me, of the cochlear implant? Can we use our oral rehab therapist to really focus on understanding auditory information? There's also a lot of accessories to help us in situations where there is noise, to help bring up the signal that you want to hear and try to eliminate some of that competition that we all experience. I mean, you go with a friend to get coffee, think about how much competition. And if you're not getting all of the information, you have to separate that out from
Right.
what I'm trying to hear, but the
So you have to
noise and
gauge
the music and the
situations.
television.
Yeah, there's so much
There's
to put
so-
together, a
right.
puzzle. Another question, I believe, from the
Sure,
audience.
this is our last question. This one comes from Anthony. My wife has a hearing aid and diabetes. Can you tell that Cochlear is needed, and does insurance pay for it? What is the typical cost?
So insurance, Medicare, all cover cochlear implantation. Depending which commercial carrier or Medicare, they all have different criteria specifically about how bad does your hearing loss have to be and how bad does it have to be in both of your ears to qualify. There's a specific test battery that we use for folks who say, yeah, I'm seeing a good audiologist, I've been wearing hearing aids for years, I'm no longer getting the benefit that I really need to have. Send them on in. We put them through this comprehensive test battery to really ascertain yes or no, is this patient a cochlear implant candidate? And if they are a candidate based on that hearing test number, it's paid for by all the third-party payers.
Is there a downside to a cochlear implant?
I can take down. So, is there a downside? Look,
I mean,
it's
I'm
a-
not hearing any
It's a
negatives.
it's a surgery. It's a surgery and it's a commitment. Right? So think of, we're talking about how does your brain respond and how does the small vessel disease respond to this. When you get a hip replacement, you go to physical therapy for months and you have exercise to do every day at home. It isn't you flip a switch and now your hip is perfect and there you go. This is an implant for your ear, and it requires a level of dedication to say, I'm going to come for the follow-up visits that are necessary. And we've drastically reduced the number of those, but there are still some, so there's travel costs and time away from work. And then there's the dedication to say, I'm going to wear this all day long. I'm going to go around people who are talking all day long. I'm going to make use of the online resources and the teaching and the support groups to really get the best level of function I possibly can. For folks who are willing to put in that energy and that dedication, they do phenomenally well. It's probably the most rewarding thing either of us do in our professional lives. But you don't take it lightly. It's still a surgery that has risks associated with it, and you just have to have a lot of education up front.
Do you ever see a patient who's too far gone that you cannot do anything for them?
We look at the outcome of patients. So the longer you've had your hearing loss, especially if you haven't managed it, our expectations of that patient are much lower than someone who's managed properly, used hearing aids. And we should probably preface that as part of that test battery that Dr. Kaplan was talking about, patients do have to have a hearing aid trial period. So you can't go right from, I think I have a hearing loss, to getting a cochlear implant. We want to rule out that there's nothing that can be done non-surgically that would end up with good results.
Denial for a number of years, and they finally got to a point where someone has maybe even convinced them, you can make a change, you can get it, this can be helped. I mean, do they wait? Is there a point where you wait too long?
So, look, there's an average of a 12-year wait right now when someone becomes a cochlear implant patient to when they get into the channel to see us. So we're working very hard on decreasing that 12-year gap, and all those denial issues and access to care and education all play a role in that discussion. The only folks who you'd say are probably not great candidates, like Regina talked about, people with many decades of no hearing at all in that ear. If children were born with no hearing and are now coming in as adults, never having developed language, we can give them sound awareness with a cochlear implant, but they will not be able to develop speech. But for the vast majority of folks, these are folks with progressive hearing loss, have been wearing some hearing aids, are no longer getting the benefit they need to, and they can receive often extraordinary benefit with an implant.
Okay, so I guess the message here is if you're dealing with diabetes or if you're pre-diabetic, don't forget your ears.
Perfect.
Right?
Perfect.